Very good morning. Today I'm going to present in front of you my lecture, which is on Perio Endo lesions and its treatment. So we'll be covering our lecture under the following headings: Introduction, Pathways of Communication, Classification of the Pulpal Diseases and Periodontal Diseases, Classification of the Perio-Endo lesions, Etiopathogenesis of Perio-Endo lesions, Diagnosis of the Perio-Endo lesions, and the Management of the Perio-Endo lesions. So let's start with the introduction. What are Perio-Endo lesions? How do they exist? Simultaneous existence of the pulpal problems and the inflammatory periodontal disease can complicate the diagnosis and treatment planning, can affect the sequence of the care to be performed. So the tooth, the pulp tissue and its supporting structures should be viewed as a one unit because there exists an interrelationship of these structures and which influences each other during their health, function and the disease. Periodontium communicates with the pulp tissue through many channels or pathways, and these channels may be involved in extending pulpal inflammation or infection to the periodontium and vice versa. So we are just talking about that there may be simultaneous existence of the diseases which may be through the pulpal problems, or maybe some inflammatory periodontal disease may also exist simultaneously or may exist alone. But when they exist simultaneously, they may complicate the diagnosis and the treatment planning, because then we will have to decide the treatment accordingly. And also, as during the growth and development, all the structures of the tooth and the surrounding structures, they have been developed from a common source of origin and the mesoderm. So there exists a communication or a relationship between these structures. So whenever one structure is affected, there are chances that it may involve the surrounding structure also. The relationship between the pulpal and the periodontal disease can be traced to the embryological development, since the pulp and the periodontium are derived from a common mesodermal source. In the course of the root development, strands of the mesodermal tissue may get entrapped and later become lateral and accessory canals. These canals form when epithelial root sheath that breaks down before the root formation is complete, or when the dental papilla and the dental sac persist and they combine each other. Dentine or deposition of the cementum, some of the communications between the pulp and the periodontium may remain patent in the adult dentition. These offshoots also may result from dentine formation around existing blood vessels or a loss of continuity of the Hertwig root sheath during dentine formation. So during the development, which they occurs from the common source, that is mesoderm, and so there exists an interrelationship. And when the Hertwig epithelial root sheath, if it breaks at the point before the root formation is complete, then exists a communication between the between the various structures. Okay. In time, most of these communications are sealed by cementum or secondary dentine, leaving the pulp basically dependent on the apical foramen for metabolic exchange, and thus forming a low compliance system. Some of these portals of communication remain patent, however, and these, in addition to the apical foramen and dentinal tubules, are pathways through which etiological agents may pass between the pulp and the periodontium. So this is a diagram which is showing the interrelationship. What are the pathways that may cause the communication between these two structures? So before that, the interrelationship between the periodontium and the pulp was first discovered by Simmering and Goldberg in 1964. So this is a tooth structure. So this is a tooth structure, and this is the gingiva, periodontal ligaments. Then periodontal ligament space is there. This is the alveolar bone, and the root is covered by the cementum. So these communication, how do these two separate structures communicate? It has been told that during the development and growth, certain accessory canals or the lateral canals develop, and which makes a communication between the tooth structure and the surrounding tooth and the surrounding structure. So these are the lateral canals, these are the accessory canals, And there is a apical foramen, which is the major source, and then comes the dentinal tubules, which may also be exposed. Periodontic endodontic lesions are localized, circumscribed areas of bacterial infection originating either from the dental pulp, periodontal tissues surrounding the involved tooth or teeth, or both. The incidence of accessory canals is 2 to 27%, and majority of these canals occur in apical portion of the root with decreased numbers in the furcation areas. So this is a radiograph showing the existence of apical foramen and the accessory canals. Perio-endo problems are more in molar than anteriors. Why? Because more accessory canals are present in the molars. Nearly 46% lateral canals are present in first molar and 50 to 60% in multi-rooted teeth. So this is again a picture showing the tooth with the accessory canals, apical foramen. There are lateral canals are may also present, which is not shown here, and these are the exposed dentinal tubules. Now, how does it happen? Those these happen, these communication happen with the help of certain pathways. So there are certain pathways of communication which are divided into basically into anatomic pathways and non-physiological pathways. So anatomic pathways, also called as physiological pathways, there are two types, basically categorized as vascular pathways and tubular pathways. Through vessels or the blood supply, these are the apical foramen. These pathways occur through the apical foramen and the lateral canal through the blood vessels, and then the tubular pathway is through the dentinal, open dentinal tubules. So anatomic pathways of communication, accessory or lateral canals. These canals are potential pathways for the spread of bacterial and toxic byproducts, resulting in direct inflammatory process in the periodontal ligament. These canals contain connective tissues and vessels that connects the circulatory system of the pulp with the periodontium. Accessory canals also seen in the furcation area. Radiographic indication of the presence of lateral canals before obturations are there may be localized thickening of the periodontal ligament on the lateral root surface. Now comes the apical foramen. Apical foramen is the principal and the most direct route of communication between the pulp and the periodontium. The blood supply maintain a connection between the tissue via the apical foramen. When bacterial plaque involves the main apical foramen, compromising the vascular supply of the pulp, they cause pulpal pathosis. So apical foramen is the principal and the most direct route of communication between the pulp and the periodontium. Also, the bacteria and the various byproducts reach the periodontium from the pulp through the foramen and cause destruction of the periodontal tissue fibers, and bone resorption may occur. Now comes the dentinal tubules. Exposed dentinal tubules in the areas of the denuded cementum may serve as a communication pathway between the pulp and the periodontal ligament. Exposed dentinal tubules may occur due to the periodontal diseases, periodontal procedures, surgical procedures, or developmentally when the cementum and enamel do not meet at cemento-enamel junction, thus leaving the dentine exposed areas. Now, there are certain other non-pathological pathways. These includes iatrogenic root canal perforations, improper manipulation of endodontic instruments, resorptions, internal root resorption, external root resorptions, vertical root fractures caused by trauma which occurs in both vital and non-vital tooth. Root fractures more in roots then are filled with the lateral condensation techniques and teeth restored in intracanal post. So this is a diagrammatic representation showing how a healthy pulp can become a necrotic infected pulp. So if there is an infected periodontium, so this microorganism may and their byproducts may pass through the apical foramen, or it may also pass through the vertical root fractures or any other iatrogenic sources to the healthy pulp, and this healthy pulp may get change into the necrotic pulp. Similarly, how the healthy periodontium gets to an infected periodontium, if there is a necrotic pulp, if there is pulpal inflammation, pulp gets necrotic. So through the apical foramens or the lateral canals or the dentinal tubules or the root perforation or vertical root fractures, these microorganisms and their byproducts may pass through the apical foramen to the periodontal ligament structures, and then it may proceed upward, and a healthy periodontium may get converted into infected periodontium and the disease process may start. So these pathways may result in spread of bacterial and toxic products by byproducts from pulp to periodontium or from periodontium to the pulp. Or now classification of the pulpal diseases. Classification of the pulpal disease, just a briefing. So pulpal diseases are classified as pulpitis or inflammation of the pulp. They may be reversible pulpitis, irreversible pulpitis, or pulpal necrosis. So reversible pulpitis means the reversibility of inflammation and symptoms occur without permanent pulpal damage is known as reversible pulpitis. In irreversible pulpitis, if the pulp is affected to a point that the inflammatory lesion cannot be resolved, even though source of trauma is eliminated, a progressive damage of the pulp results, and this is known as irreversible pulpitis. And there may also be third one is pulpal necrosis. Classification of periodontal disease and condition. So this is an older classification. So according to this is a periodontal diseases are classified as gingival disease and plaque-induced gingival disease, non-plaque-induced gingival diseases. Now chronic periodontitis and aggressive periodontitis are both categorized as periodontitis. So this is the newer, according to newer classification of periodontal diseases. Now there exists one term which is periodontitis, and chronic periodontitis and aggressive periodontitis are included under periodontitis. So chronic periodontitis and aggressive periodontitis. Now comes third is the periodontitis is a manifestation of systemic disease. Now necrotizing periodontal disease, which can be necrotizing ulcerative disease, necrotizing ulcerative periodontitis. Now abscesses of periodontium, gingival abscess, periodontal abscess, pericoronal abscess, developmental acquired deformities and conditions. So that was the classification of endo and perio diseases. Now we talk about the etiopathogenesis of the lesions, how the etiology leads to the pathogenesis or the beginning of the diseases. So now we will talk about the etiopathogenesis of the perio lesions. Periodontal lesions are initiated by deposits of the plaque and calculus. Bacteria are present in plaque and calculus, and the toxins produced by these bacteria can irritate the gum tissue or the gingival tissue and causes the body's immune system to turn on, or whenever there is chronic inflammation. This inflammation can break down and destroy the tissue and the bone supporting the tooth. The gingival tissue separate from the tooth, forming a pocket. This is in very simple term. So periodontal lesions are initiated by deposits of the plaque and calculus. Inflammatory mediators cause destruction of the gingival connective tissue, periodontal ligament, and alveolar bone. Alterations of the root surface occur by loss of the outer cementoblast layer and results in shallow resorptive lesions of the cementum. Endotoxins produced by the plaque bacteria also have irritant effect on the overlying soft tissue, preventing repair. Migration of the lesion to the apex continues with drainage via the gingival sulcus, preventing an acute episodes. Most authors agree that healthy pulpal tissue is highly polymerized, highly vascular tissue, and it is quite resistant to infection. So periodontal lesions, the pathogenesis of periodontal lesion is that it is basically initiated by the plaque and calculus, the inflammatory mediators, which the toxins and the microorganisms and the byproducts and their toxins induces an inflammatory reaction, and the inflammatory mediators are released. These inflammatory mediators causes destruction of the connective tissue, periodontal ligament and alveolar bone, and there is also resorption of the root structure. There is this resorption of the outer cementum layer, necrosed area of the cementum are produced, which are soft areas, and they act as a reservoir for bacterial accumulation again. And this overlying soft tissue, unless it is not removed, it prevents the repair of the tissue. All the periodontal diseases have been shown to have a cumulative damaging effect on the pulpal tissue. Total disintegration of the pulp is only occurs if the bacterial plaque involves the main apical foramina comprising the vascular supply. So we are saying that the periodontal disease may have some damaging effect on the pulp, but to have a pulp as a necrosed pulp or damaged pulp, it is important that it will occur only if the apical foramen, which is the main source, which is the main part of the root where the blood supply goes on. If it is involved, then only there are chances, and that too very less, that the periodontal disease may cause disintegration of the pulp. And it can occur only if the vascular supply through the apical foramen is hampered. Now, pathogenesis of endodontic lesions. Endodontic lesions. Pulpal inflammation and necrosis are initiated by the dental caries. Resorptive procedures, trauma, chemical irritation, and severe thermal stimulation are some causes. These inflammatory lesion causes localized edema and resulting in increased intrapulpal pressure and cell death. Increased damage associated with an inflammatory exudate causes local collapse of the venous part of the local vasculature. This causes local tissue hypoxia, anoxia, resulting in localized necrosis, the chemical mediators of which further localized edema, completing the cycle, as the root canal system is a low compliance. Increased intrapulpal pressure may cause toxic agents to be expressed through patent canals such as apical, foramen, lateral and accessory canals and dentinal tubules, which can result in retrograde periodontitis. So it is saying whenever there is an inflammation in the pulp, and the intrapulpal disintegration of the pulp occurs, there is raise in the intrapulpal pressures. Okay, necrosis occurs. When the intrapulpal pressure increases, it may cause the toxic agents to be expressed out, to be taken out through the patent channels such as apical, foramen, lateral and accessory canals, dentinal tubules. So now from here, the disease from the root will now travel via the periodontal ligament to the sulcus area, and now this will involve the will cause the inflammation in the periodontium, and this kind of periodontitis, because it is starting from the apex and reaching to the sulcus, it is a reverse direction, so it is known as retrograde periodontitis. But retrograde periodontitis is quite rare. Noxious agents from a root canal which cause a clinically detectable inflammatory lesion in the surrounding periodontal ligament have been shown to originate from a non-sterile necrotic pulp or remnants of such unfilled spaces in inadequately filled tooth. Carious lesions or any direct exposure to the oral cavity of dentine or pulp may allow ingress of bacteria to contaminate an otherwise sterile lesion. This is predominantly mixed anaerobic infection. Endodontic lesions are most frequently initiated and sustained by the apical foramen, followed by accessory and lateral canals, and most infrequently by dentinal tubules. Now, etiopathogenesis of endo lesions. So there are three factors: physical, chemical, and bacterial, which may contribute to etiology of the endodontic lesions. So first is physical. Under physical comes the mechanical. So mechanical may there may be trauma to the canal, pulp chamber. It may be accidental or iatrogenic dental procedures like wedging of teeth, cavity or crown preparation. There may be pathological wear like atresion, abrasion, etc. Cracked tooth syndrome or barometric changes. Thermal etiology includes heat from cavity preparation at either low or high speed, exothermic heat from setting of the cement, conduction of heat and cold through deep filling without protective base, frictional heat caused by polishing or restoration, electrical, or that means to galvanic current from dissimilar metallic fillings. Chemical may be leaching through the phosphoric acid or acrylic monomer. Bacterial means toxins associated with the caries. There is direct invasion of the pulp from the caries or trauma. So mostly the bacteria which are associated with the pulpitis are Eubacterium, which is a gram-positive non-motile bacteria, Peptostreptococcus, which is again gram-positive non-motile, Porphyromonas, gram-negative non-motile, Prevotilla, which is also gram-negative non-motile, Volonella, gram-negative and motile. These are the few microorganisms associated with the pulpitis. Pulpal tissue may be significantly inflamed and get little or no effect on the periodontium. So when the pulpal tissue is inflamed, it may have little or no effect on the periodontium. If the pulp remains vitous, it is unlikely that significant changes will occur in the periodontium. So if the pulp is vital, the periodontium most likely will not be affected. Pulp necrosis may cause bone resorption and producing radiolucency at the tooth apex, furcation, or along the length of the tooth. So this is a picture showing retrograde periodontitis. Actually, there is We have read about the marginal periodontitis, means from the gingival sulcus, because of the plaque in calculus, the periodontitis starts from after gingivitis, the periodontitis start and it proceeds downward is the root apex if it is untreated. But if pulp infection, the second scenario may be pulp infection may cause tissue destructive processes that proceeds from the apical region of the tooth to the gingival margin, and because the hair the mode is from the opposite direction, it is known as retrograde periodontitis. Impact of periodontitis on the dental pulp. So we have read what is the impact of pulpal disease on periodontium. So we have read if will be an intact blood supply through apical foramen, there won't be any change of the pulpal disease to the periodontium unless the blood supply is hampered. Now second scenario is impact of periodontitis on the dental pulp. The pathogenic bacteria and the inflammatory product of the periodontal disease may gain access to the dental pulp through accessory canals, apical foramen, and this is known as retrograde pulpitis. So similarly, if the pulp which gets infected via the pathogenic bacteria which travels to the lateral canal, apical canal, accessory canals, or apical foramen or dentinal tubules, and then the pulp gets inflamed or necrosed. Now this is known as retrograde pulpitis. Here the pathway of inflammation of the pulp is again reversed. Because of the intact cementum layer which protects the pulp from injurious element produced by plaque microbial agent, and also the pulp has a good capacity for defense as long as blood supply through the apical foramen is intact. Therefore, retrograde pulpitis, if it occurs, is quite rare. But pathological changes in the pulp may occur once the periodontal disease reaches a terminal stage when the bacterial plaque involves the apical foramen or exposed dentinal tubules due to denuded cementum. Now, classification of Perio endo lesions. The most commonly used classification was given by Simon, Glick, and Frank in 1972, which is like as follows: primary endodontic lesions, primary periodontal lesions, primary endodontic lesion with secondary periodontal involvement, primary periodontal lesion with secondary endodontic involvement, and true combined lesions. So classification due to the pathogenesis. So I will again go to the classification. Most commonly used classification was given by Simon, Glick, and Frank, which according to the disease where it has affected which part, it is defined as primary endodontic lesion, means the lesion is only purely of the endodontic origin. Primary periodontal lesion means the lesion is primary only of the periodontal involvement. Third is the primary endodontic lesion. The lesion was primarily endodontic, but as the disease progressed, it involved the periodontal ligaments through the accessory canals, lateral canals, or apical foramen. So here it will be primary endodontic lesion with secondary periodontal involvement. And then comes the true, the primary periodontal lesion, means the lesion was primarily periodontal. Okay, but as the lesion advanced, it involved the apical foramen, and then there was a secondary involvement of the end pulp. So here it is known as primary periodontal lesion with the secondary endodontic involvement, and the last is the true combined lesion, means both the endodontic lesion and the periodontal lesions are both present, and they will unite at some point. So both the lesions are present. Classification due to their pathogenesis: periodontal lesion, endodontic lesion, and inflammatory process in the periodontal tissue resulting from accumulation of dental plaque on the external root surface. Endodontic lesions, an inflammatory process in the pulpal tissue resulting from noxious agents present in the root canal system of the tooth. True combined lesions, both endodontic and periodontal lesions developing independently and progressing concurrently, which meet and merge at a point along the root surface. And iatrogenic lesions means usually the endodontic lesions are produced as a result of wrong treatment modalities. Simon, Glick, and Frank further categorized endodontic lesion into subcategories. Primary endo lesions, when sinus tract has been formed to establish drainage. Primary endo lesion with secondary periodontal involvement. when plaque formation occurs with progression of periodontitis and associated calculus formation. An acute exacerbation of a chronic apical lesion on the tooth with necrotic pulp may drain coronally through the periodontal ligament into the gingival sulcus. This condition may mimic clinically the presence of periodontal abscess. In reality, it is the sinus tract from pulpal origin that opens to the periodontal ligament area. So this is very important because it may appear as if there is a periodontal abscess, but actually it is a periapical abscess. Okay, so acute exacerbation of the acute chronic periapical lesion in the tooth with a necrotic pulp may drain coronally through the gingival sulcus and through the periodontal ligament space through the gingival sulcus, and it may appear that there is a periodontal abscess. But when you probe, you will find no, it is not a periodontal abscess. There are no periodontal findings. This is a sinus tract from the pulpal origin. So this is one of the factors which has to be considered while doing careful probing. The most convenient classification of endodontic was given by Simon et al. Now, Grossman classification: Group 1, lesions that require endodontic procedures only. Group 2, lesions that require periodontal treatment procedures only. Group 3, lesions that require combined endodontic periodontic treatment procedures. Lesions that require endodontic treatment procedures only are necrotic pulp and apical granulomatous tissue with or without sinus tract. Chronic periapical abscess with the sinus tract draining through gingival sulcus. Root fractures, root perforations, teeth with incomplete apical root development, endodontic implants, transplants, orthoplants. These may require endodontic treatment. Lesions that require periodontal procedures only. There may be some trauma from occlusal trauma, which may causing reversible pulpitis, occlusal trauma plus gingival inflammation resulting in pocket formation. This is a radiograph showing primary endodontic lesion. Primary endodontic lesion in the mandibular first molar, a preoperative radiograph showing periapical and interradicular radiolucency. Periapical and interradicular radiolucency. Radiograph was taken after completion of the root canal treatment, and this is a 2-year follow-up of radiograph. We show that a good endodontic therapy with time healed the radiolucencies, and there was a bony healing. Simon, Glick and Frank also further categorized periodontal lesions into 2 subcategories: primary periodontal lesions with secondary endodontic involvement. When there is progression of periodontal lesions to involve the apex of the tooth and the pulp is vital, there may be some pulpal degenerative changes. So when there is primary periodontal lesions, the pulp is vital. Primary periodontal lesion with secondary endodontic lesion, periodontal disease causes a resultant pulpal necrosis as it progresses apically. And when there will be a secondary endodontic involvement, though there will be, you won't find any caries or any other iatrogenic factor like root fractures or any other etiology which may harm the pulp. In that case, if the lesion will be, the pulp is non-vital, in that case it will be a primary periodontal lesion in which there will be endodontic involvement secondarily. The lesions are caused primarily by periodontal pathogens. In this process, chronic periodontitis progresses apically along the root surface. In this process, chronic periodontitis of the lesion progresses apically along the root surface. In most cases, pulp test indicates a clinically normal pulpal reaction. There is frequently an accumulation of the pulp and calculus are deeper, then only the apical foramen may be involved, and in that case there will be a negative pulpal response. Primary endodontic lesion with secondary periodontal involvements. There is an endodontic lesion. If the lesion is primarily endodontic and it remains untreated, it may become secondarily involved with the periodontal breakdown. Plaque accumulation at the gingival of the margin of the sinus tract leads to plaque-induced periodontitis in this area. And this lesion may also occur by root perforations during root canal treatment or pin and post may have been misplaced during restoration of the crown. Symptoms may be acute with periodontal abscess, formation associated with the pain, swelling, pus or exudate, pocket formation, and tooth mobility may be there. Chronic response occurs without pain and pocket with bleeding or probing or exudation of the pus. This is a picture showing primary periodontal lesion with secondary endodontic involvement. The apical progression of the periodontal pocket may continue until the apical tissues are involved. In this case, the pulp may become necrotic as a result of infection entering via lateral canal or apical canal. So, if the primary lesion is primarily periodontic, but if it remains untreated for a longer duration of time, so it may go deeper down and may involve the apical foramen infra. When the blood supply of the pulp is hampered, it may lead to the infection may also transfer via the lateral accessory canals, dentinal tubules, apical foramen, and the pulp may become necrosed. In single-rooted tooth, the prognosis is usually poor. In molar teeth, the prognosis may be better since not all roots may suffer the same loss of supporting tissues. Root resection can be considered as a treatment alternative. The treatment of periodontal disease can also lead to secondary endodontic involvement. Lateral canals and dentinal tubules may be opened to oral environment by scaling and root planing or surgical flap procedure. So this is the explanation how periodontal disease can also lead to secondary endodontic involvement. While we are doing scaling and root planing, it may lead to exposure of the dentinal tubules. Okay, so that it becomes a pathway is formed. It is possible for the blood vessels within the lateral canals to be severed by curette and for microorganisms to be pushed into the area during the treatment, resulting pulpal inflammation and necrosis. Now, the true combined lesion, the true combined endoperiodontal lesion occurs less frequently than other endodontic periodontal problems. The combined lesions are less frequent. It is formed when the endodontic lesion progresses coronally joins with an infected periodontal pocket progressive apically. Means both the lesions existed. There was a true endodontic lesion. There was a true periodontal lesion because of the plaque and calcareous accumulation. The disease progressed and caused attachment loss. And when it reached apically, both the lesions joined together at some point of time. The degree of attachment loss and type of the lesion is large and the prognosis is guarded. If there is a attachment loss is severe, then the prognosis of the tooth is guarded even if the endodontic therapy is successfully done. Particularly true in single-rooted tooth. In molar teeth, root resection can be alternative treatment. If the sinus tract is present, it may be necessary to raise a flap to determine the etiology of the lesion. Now, how to do the diagnosis of the endoperio lesions? The most common important factor in the treatment of perioendo lesion is correct diagnosis. This is achieved by careful history taking, examination, and use of special tests. Clinical tests are imperative for obtaining correct diagnosis and differentiating between endodontic and periodontal disease. Advanced lesion and true combined lesions are difficult to differentiate between, and therefore where doubt exists, they should be considered as endodontic lesion. So very important factor in treatment of perioendo lesion is the correct diagnosis. So we have to take a careful history examination and use of special tests. So these are the showing certain clinical findings in endo and periodontal lesions. In periodontal lesions, the cause is periodontal infection. In endo, it may be pulpal infection. Vitality, perio lesions, pure perio lesions, pulp is vital. In endo lesions, it is non-vital. Plaque and calculus present in perio lesions, absent in endo lesion. Not an etiological factor. Caries is absent perio lesion, primary perio lesions, present in primary endo lesions. Pockets present. Multiple pockets may be present, single narrow according to that tooth. Mobility may be present or absent. Microbiota is complex, it is few. Radiological features, pattern of the bone loss is wider coronally and wider apically. Okay. It may be generalized, it may be localized. Vertical bone loss may be present here, no bone loss. No vertical bone loss. Periapical pathology non-related, radiolucent findings may be found. Clinical findings, other are pulpal status. Combined lesions may the pulp will be necrotic, in endo lesion it will be necrotic. Perio status, periodontitis, and endo lesion normal. Probing, wide pocket may be present, maybe narrow pockets may be present. Plaque and calculus, combined lesion may be present. Endo lesion, it will be absent. Treatment of combined lesion will be combined, both endoperio treatment will be periodontal treatment, treatment of the lesions of the periodontal origin, and treatment of the lesions of the endo origin. Both will be treated simultaneously. In endo lesion, only endo treatment will be there. In prognosis depends. In the combined lesion, the prognosis depends upon the perio part. How much is the attachment loss is there? If there is little attachment loss, the prognosis of both the treatment will be good. But if there is attachment loss is severe, there is a root resorption is there, then it depends upon how much bone support is present. Okay. And in endo lesion, if it is primary endo lesion, the prognosis is generally good. Various diagnosis procedures that can be used to identify perioendo lesions are visual examination, palpation, percussion, mobility, radiographs, pulp vitality testing, pocket probing, fistula tracking, cracked tooth testing. Visual examination, examination of the soft tissue, attached gingiva and alveolar bone for the presence of inflammation, ulceration or sinus tract. The teeth are examined for abnormalities such as caries, defective restorations, erosions, abrasions, cracked teeth, fractures and discoloration to identify the etiology. A discolored tooth may be associated with necrotic pulp, and a pink spot detected may indicate an internal resorption. Visual examination is improved by magnification and illumination. Percussion. This test enables one to evaluate the status of the periodontium surrounding a tooth to determine whether the tooth is tender. It indicates the presence of periradicular inflammation. If the tooth is tender, it will indicate the presence of periradicular inflammation. Patient response obtained during percussion as body movement, reflex pain reaction, or even as unspoken responses observed. Palpation. This is done with the help of fingertips using light pressure to examine tissue consistency and pain response and determine the following: whether the tissue is fluctuant and enlarged sufficiently for incision and drainage, and the pressure, intensity and location of the pain. A positive response to palpation may indicate active periradicular inflammatory process. This test does not indicate whether the inflammatory process is of endodontic or periodontal origin. Mobility and depressibility. Mobility test is used to evaluate the integrity of the attachment apparatus surrounding the tooth. The amount of movement might be indicative of the condition of the periodontium. Radiographs. Detection of carious lesions, extensive or defective restorations, pulp caps, root fractures, periradicular radiolucencies, thickened periodontal ligament space, and alveolar bone loss may be seen. Periodontal diseases causing alveolar bone loss and the presence of calculus can be effectively detected by radiograph. Pocket probing. Periodontal probing is an important test that should always be performed when attempting to differentiate between endodontic and periodontal disease. Because if there will be a periodontal disease, you can find periodontal pockets of variable depths. A blunt calibrated probe is used to determine the probing depth and clinical attachment level. Probing technique. The probe should be inserted parallel to the vertical axis of the tooth and walked circumferentially around each tooth surface to detect area of deepest penetration. A deep solitary pocket in absence of periodontal disease may indicate the presence of a lesion of endodontic origin for a vertical fracture. Multiple deep wide coronally pocket indicate presence of lesion of periodontal origin. Periodontal probing can be used as a diagnostic and prognostic aid. The prognosis of the root canal treatment in a tooth with severe periodontal disease is dependent on the success of periodontal therapy. Therefore, correct identification of etiology of the disease, whether endodontic, periodontal, or combined, will determine the course of the treatment and the long-term prognosis. Another test is fistula tracking. Endodontic or periodontal disease may sometimes develop a fistulous sinus tract. Intraorally, the opening is usually visible on the attached buccal gingiva or in the vestibule. Extraorally, the fistula may open anywhere. The identification of the sinus tract is by simple visual examination does not necessarily indicate the origin of the inflammatory exudates or tooth involved. So identifying the source of inflammation by tracing the fistula will help the clinician to differentiate between disease of endodontic and periodontic origin. Fistula tracing is done by inserting a semi-rigid radiopaque material into the sinus tract until the resistance is met. Commonly used for sinus tract are gutta percha cones or pre-soft silver cone. A radiograph is then taken which will reveal the course of sinus tract and origin of the inflammatory process. Cracked tooth testing is done by transillumination, wedging, or staining. Now we will talk about signs and symptoms of the periodontitis. Periodontitis is a chronic inflammatory lesion that begins in marginal gingiva and extends apically, causing attachment loss and periodontal pocket formation. In general, progression rate of attachment loss is slow unless an acute event such as periodontal abscess occurs. The patient may be unaware of the condition except for the bleeding on brushing. Pockets may be tender to probing. Probing may be usually accompanied by the bleeding. Signs and symptoms of pulpal diseases. The pulp has the ability to respond to the stimulus through enamel or dentine or directly to the pulp. The character of the pain may vary with its source. Initiation of the pulpal sensation by stimulating dentine is usually fast, sharp, and severe and mediated by A delta myelinated fibers. Sensation from the core of the pulp initiated by smaller unmyelinated C fibers. Pain is described as being slower, duller, and more diffuse. The only symptom a patient with reversible pulpitis may report is sensitivity to hot or cold fluids. The period of discomfort is usually brief, whereas in irreversible pulpitis, there is severe pain, and this pain may be intense and is often described as bright, unoffered throbbing. If the inflammatory process extends to involve the periodontal ligament, the affected tooth can become tender to percussion, pressure, biting, or light tapping with an instrument. Necrosis of the pulp can result in bony resorption. Thus, pulp death may result in radiolucency at the apex of the tooth infurcation at points along the root. Now we will talk about the treatment of the perio-endo lesions. The most important factor in the treatment of the perio-endo lesion is the correct diagnosis. This is achieved by careful history taking, examination, and use of special tests, just we have read about, as well as understanding of the pathogenesis and a clear classification. The main factors to consider are pulp vitality and type and extent of periodontal defect. In primary endodontic lesion, the pulp is infected and non-vital. In primary periodontal lesion, the pulp is vital and responsive to testing. Treatment, initial consideration before any kind of advanced restoration work to treat the perio-endo lesion, the prognosis of the tooth should be consideration should be done carefully. Whether there is a functional need for the tooth, whether the tooth is restorable after the lesion has been treated, and whether the patient is suitable for a lengthy, costly, and invasive treatment. If any of these factors are deemed negative, extraction is the treatment of the choice. So we start with the treatment of primary endodontic lesion. Before that, we have just read that before starting any treatment, it is very important to know about the careful history taking is very important. It should, then reaching up to a diagnosis may be accompanied with certain tests. so that we are able to, we are like vitality test, probing, careful probing, so that we can reach up to a conclusion whether the lesion is of endodontic origin, or it is of periodontal origin, or it is a combined lesion. Okay. And the success of the treatment or the prognosis of the treatment depends upon how much is the perio part is involved, how much there is a periodontal attachment loss is there. So we will talk about all these things in the coming slides. So treatment of primary endodontic lesion. Conventional endodontic therapy alone resolve the treatment, will alone resolve the treatment. So if there is only primary endodontic involvement, the endodontic therapy will resolve the lesion. Debridement of the pulp chamber and canals as well as completion of appropriate endodontic therapy are sufficient to result in healing of the lesion. Pulpal abscess and apical lesions generally resolve with conventional therapy. Occasionally, an abscess of pulpal origin through an apical or lateral canal may establish drainage through periodontal ligament and erupt into furcation. Therefore, it becomes very necessary to separate signs and symptoms of pulpal disease from those associated with periodontal abscess. The patient's history, periodontal probing, radiographs, and pulp testing should be consistent with the pulpal disease. Root canal treatment resolves any tract present. So we have read that if the lesion is only of the primary periodontic origin, endodontic therapy will be of choice and it will heal the lesion. But sometimes it happens that there will be abscess drainage through the lateral canals, and this drainage is done through the periodontal ligament, and then it may come through the sulcus area also. So here there may be a confusion regarding if it is a pulpal abscess or a periodontal abscess, pulpal abscess or periapical abscess. So here careful probing may be done to reach up to a conclusion. Treatment of primary periodontal lesion. They are treated by non-surgical phase therapy. First, poor restorations and then in the developmental grooves are removed, as these are difficult areas to treat successfully. Also, these are the plaque retentive areas. Periodontal surgery is performed after the completion of the phase 1 therapy. The patient is kept on maintenance therapy, and when it is he or she is recalled, rechecking, reprobing is done, and all those areas which have not in which the pocket reduction has not been done, they may be taken up for further periodontal surgery or periodontal treatment. Treatment of primary endo lesion with secondary periodontal involvement. These lesions do not completely resolve only by endodontic treatment. Root or re-root canal treatment done immediately, and cleaned and shaped canals filled with calcium hydroxide paste. The canals are obturated with conventional material when there is clinical improvement. The phase 1 therapy should be initiated immediately, although deep scaling and periodontal surgery to resolve periodontal disease area should be postponed until the endodontic part of the lesion is not resolved. Prognosis of primary endo lesion is good, but the prognosis of the lesion depends upon the effectiveness of the periodontal treatment. So we have read if there is a primary endodontic lesion with secondary periodontal involvement, first the endodontic treatment has to be completed. After that, the phase 1 therapy is started. And the prognosis of the primary endo lesion with the secondary periodontal involvement depends upon the effectiveness of the periodontal treatment. Treatment of combined periodontal and endodontic lesions. The true combined lesions result from the development and extension of endodontic lesion into an existing periodontal lesion. Such lesions may present with the characteristic of both the diseases, which may complicate the diagnosis and the treatment sequencing. A careful history and thorough clinical examination and radiographic examination are required. Usually, the developing periapical lesion extends coronally to connect the pre-existing chronic wide base pocket. On rare occasion, a developing periodontal lesion associated with development group may extend apically to connect with the apical or lateral endodontic lesion. So it says that usually a developing periapical lesion may extend to connect the periodontal pocket, but on rare occasion it occurs that a periodontal lesion may extend apically and then connect with the apical or the lateral endodontic lesion. Also, if periodontitis progresses to involve a lateral canal or apex of the tooth, a secondary pulpal infection may be induced, referred to as retrograde pulpitis, though very rare. Pain from the loss of the pulp vitality is the most common presenting complaint of the patient with the combined lesions. Symptoms are those that are found in the pulpal disease. Thermal testing will tell us about the status of the pulp. Radiographs will tell about the presence of apical changes and presence of bone loss. Careful probing confirms the presence and morphology of periodontal pocket and permits the location of the communication with the apical lesion. The periodontal portion of the defect is usually plaque, calculus, or root roughness as a finding. The extent to which a periodontic lesion contributes to the loss of the bone is key consideration in the diagnosis and the treatment planning. So it means how much bone loss is there will be a key consideration in the diagnosis and the treatment planning. Endo treatment, when appropriately performed, the alterations in the radiographic appearance and clinical probing disappear. So when the endo treatment is performed appropriately, the periapical radiolucency or interradicular radiolucency on minor probing which was present may disappear with time. The periodontal component of the combined lesion presents difficulties. It cannot resolve as long as the endodontic lesion is present. But effective endodontic treatment cannot eliminate periodontal pocket. The ability to eliminate the periodontal component of the defect ultimately dictates the treatment of the tooth. If the majority of the bone support has been lost from the periodontitis, regardless of the predictability of the endodontic treatment, the tooth may have hopeless prognosis. So, major factor is how much attachment level or how much bone level is present, clinical attachment level, what is the status of the clinical attachment level, or how much is the bone loss present. Once the decision to retain the tooth is made, endodontic therapy should proceed. Attempts at periodontal pocket elimination will be done. The periodontal therapeutic objectives vary with the extent and configuration of the residual periodontal lesion. So, periodontal treatment includes scaling, root planing, as well as various pocket elimination or reduction surgical treatments. If endodontic lesion requires apical surgery known as, or episectomies, the surgical treatment of both apical and periodontal lesions may be accompanied simultaneously. Now, what is the prognosis of the combined lesion? With proper treatment, the healing of endodontic lesion is highly predictable. We all know if we will do proper root canal therapy, endodontic lesion is high chances that higher predictability is there. However, the process of prognosis of combined lesion varies with the extent the lesion contributes to loss of attachment. Pulpal lesions resolve with endodontic therapies, whereas the repair or regeneration of attachment loss from periodontitis is less predictable. The long-term prognosis for the tooth with a combined lesion is therefore closely related to the extent and configuration of the periodontal attachment loss. So we know that how much periodontal attachment loss has occurred will define our treatment. With advanced horizontal bone loss, even an optimal endodontic result may not be sufficient to retain the tooth as functioning member of the dentition. If the root to ground to root ratio is altered because of the bone loss, then even if there is a good endodontic therapy, the chances is less. If there is angular multi-walled bony defect, the success of therapy likely depends upon the ability to full or regenerate attachment to obliterate the defect. So now we reach up to the conclusion. The perioendo lesions developed by the extension of either periodontal destruction apically combining with an existing periapical lesion or an endodontic lesion marginally combined with an existing periodontal lesion. The differential diagnosis between periodontal and endodontic origin can usually be established by careful history taking, clinical examination, and radiographs. The combined periodontal and endodontic therapy is essential for successful healing of the perioendo lesion. In combined perioendo lesion, it is generally wise to treat the endodontic component first because in many cases this will lead to complete resolution of the lesion. Treatment and prognosis of the primary endodontic and periodontal disease is very straightforward, but in combined lesion, it depends upon the periodontal disease and its response to periodontal treatment. Thank you.